This is a mature, fairly intumescent cataract in a pretty young individual. And unfortunately, the initial part of the surgery wasn't recorded. Started recording from after staining the capsule and initiating the rhexis. So here I am putting in some heavy OVD initially before initiating the rhexis. You can see that the cataract is extremely intumescent. You can see the egress of the cortex. So I am going slowly. The heavy OVD is definitely helping, and I am very gingerly fashioning my rhexis. It's a bit on the smaller side. Obviously, I don't want it to run away and raise the flag. So when I come to a certain point where I think it is little difficult to do with the cystitome, I then take my Utrata forceps and try to spiral out this rhexis or snail track this rhexis in order to get a larger diameter rhexis. However, as I come to the superior part, you can see I have joined it and the rhexis has still remained a bit on the smaller size. It's adequate to perform the phaco, but it's not a good idea to have such a small rhexis on the patient. Anyway, so I then go in with my Simcoe, aspirate some of that peripheral cortex and try to rock this nucleus to break any form of equatorial block. Having done that, I then go ahead and do the direct vertical chops using my Sinskey hook as a chopper, and as you can see, the nucleus is extremely soft, so it's not at all difficult to chop it. In fact, it is a little bit difficult to hold on to it, so because it is pretty soft, and it is the nuclear part is actually very small, just in the center, the hardcore nucleus, that's what I mean. So I have got two heminuclei, and here I am trying to break this one of the heminuclei into two pieces, and it almost auto fractures in my hand. Just watch that. So this is the problem sometimes with these nuclei. So I have taken out one quadrant. I have to be very careful because I have a very small rhexis. I may phaco the rhexis in my enthusiasm to get out these pieces. So I am going very carefully. So this is a pretty large piece, so I have to fracture it because before I bring out the entire fragment, and that's what I have done. My parameters are extremely low. I am hardly using 30 to 40% phaco power. Of course, my vacuum is 400 millimeters of mercury and my flow rate is 40 ml, and I am in the continuous mode. The bottle height is around 100 centimeters, and there I have taken out all the pieces. Incidentally, the patient was very apprehensive, as most young males are, and once I have done it for the nucleus, now dealing with the cortex can be pretty tricky, especially in a small rhexis, because you literally have to go into the bag, and sometimes both these leaves, the anterior and posterior, are fused so close together, you may inadvertently hold on to the posterior capsule. So make sure your port is always up. Make sure you tease out the cortex by going circumferentially, and then bring it out, because the cortex in these cases, being an advanced cataract, can be pretty adherent in the phonics, and you may by mistake, thinking it is the cortex, pull out the bag itself. So you have to be a bit careful not to cause a zonular dialysis and not to engage the posterior capsule. So if as a rule, if the cortex is really stubborn, just leave it. Don't be so insistent on it. I then put in some HPMC, increase my incision because I want to inject this IOL directly into the bag. I don't want it to become a wound assisted delivery of the IOL. So I go, see, I am dipping down into the bag and releasing it, so that I don't have to manipulate this into a small rhexis. And that's done. These IOLs are fairly easy to inject. Now I cannot leave, you can see that the rhexis margin is almost towards the center of the IOL. So I just make a small nick with my micro scissors, and using my micro graspers or micro rhexis forceps, I scallop that area, and that's an adequate rhexis. After that, I remove off all the HPMC, put in my intracameral antibiotic, and conclude my surgery. Thank you so much for watching.